Good evening, class. So, as promised, we will be doing a flip class for diabetes mellitus. This topic is really a very broad topic, and patients with diabetes mellitus forms the bulk of endocrinology practice, and it compasses a lot of aspects in the treatment of patients, from medications to monitoring to diet to exercise, comorbid conditions. There are a lot of things that really needs to be talked about with diabetes mellitus, but I will try my best to cover all the things you need to know at your level for this flip class. So again, this is Dr. Anna Angelica Macalalad Josue. Welcome to today's flip class. So this is Leonard Thompson, one of the um, well-documented cases of the first few recipients of insulin in the 1920s. So on January 11, 1922, Leonard was then a 14-year-old boy who was dying of diabetes. Most likely this is type 1 diabetes. And he was the first human experimental dose of insulin. So at that time, he was drifting in and out of a diabetic coma and only weighed 65 pounds. So just imagine you're 14 and you're only 65 pounds. So after an impure form of insulin failed during that time, they were able to isolate an insulin. I think this was from dogs, and this insulin, after being injected to him, helped restore his blood glucose levels back to normal, and his symptoms started to disappear. Unfortunately, after several years, when he became 27 years old, he died of pneumonia. Okay, and this was thought to be a complication of diabetes. But at least it helped him for quite some time. So, at the end of this lecture, the student should be able to, number one, characterize the global and local burden of diabetes mellitus. Second, we will be reviewing the regulation of glucose homeostasis. So you'll be able to understand the basis for the treatment, as well as the behavior of your patients, glucose levels, and then we will be trying to explain the pathophysiology of DM. You guys should be able to classify a patient with DM and be able to diagnose a patient with DM. And after diagnosing a patient, you should be able to formulate and approach the treatment with DM. And lastly, if we still have time, we're going to have to learn the complications of DM and the initial approach to their management. So did you know that India has the largest number of people suffering from diabetes in the world? I didn't know that until I started researching about the epidemiology of DM in your country. So because of this, I think DM is one of the most important topics in internal medicine, because whether you become an internist, a surgeon, an ophthalmologist, a general practitioner, or even a non-practicing individual, you will be able to encounter patients with diabetes, and your relatives will be asking you about your diabetes. So I hope you pay attention to this topic. Okay. So diabetes has been termed as a global emergency because its prevalence has been increasing in epidemic proportions. So right now, in 2013, this is from Harrison. At the time, the global estimate for the number of people with diabetes was at 382 million. So this is the IDF data from 2017, and it shows here that I think there's a significant increase in the total number of people with diabetes worldwide. As you can see, In the IDF, the Philippines is counted as under Western Pacific region. And in this region, you have about 159 people, and it's expected to increase to 183 million in 2045. And in Southeast Asia, where India belongs to, there are approximately 82 million people with diabetes, and it's expected to rise by about 84% to 151 million in 2045. And the total of number of adults with diabetes continues to rise throughout the years. And this is just from 2000. And you can see this the gradual rise of the epidemic of diabetes mellitus. So it increased by about, I think, threefold from 2000 in just a span of 17 years. So that's a big jump. Um, so why do you think um, this epidemic is happening in the world? So right now, 4 out of 5 people with diabetes live in low and middle income countries here. Okay? And in 2017, people with diabetes will mostly be composed of the um, people ages 20 to 64 years old. So not very young and not very old. So this is usually the reproductive age people, the working class people, and only about 98 million will be the elderly. In 2045, because of the advancements in the treatment of diabetes, it is expected that there will be an increase in the proportion of elderly individuals with diabetes. So we will be dealing with the patients with diabetes with complications already. So they develop complications before they even die. So two-thirds of people with diabetes live in urban areas, and number will increase to three-fourths by 2045. So we believe that the lifestyle in the urban areas contributed to by stress, the availability of food, the sedentary lifestyle in the urban population really contributes a lot to the epidemic of diabetes. So 1 in 2 adults with diabetes are undiagnosed. Over 212 million people in the world, because diabetes at its early stages are largely asymptomatic. So it's really very important to know how to screen and who to screen people so that we will be able to pick them up early. Hopefully, if it's too early, we can still reverse. If it's not too early, we can treat and be able to prevent complications. So hyperglycemia in pregnancy is also a very prevalent problem. So 1 in 6 live births is affected by hyperglycemia in pregnancy. And I see this every day in my practice. Out of 12 patients, I would see at least 2 or 3 pregnant women with GDM or gestational diabetes mellitus, or people with diabetes getting pregnant, and it has the potential to result into complications of diabetes in pregnancy. Half of the 4 million people who die from diabetes are still under the age of 60. So well into their productive age years, but this is cut short because of the problem of diabetes. So the number of deaths due to diabetes in the productive population in 2017 is about 1.1 million in the Southeast Asia region and 1.3 million in the Western Pacific region where the Philippines belongs. So that's a lot of people. Okay. How about health expenditure? So diabetes is a very, very expensive disease. And in the US, um, and in the world, about 54 billion US dollars are spent in diabetes in 2015 alone. And the cost of diabetes continues to rise through the years, parallel with the rise in prevalence of your diabetes mellitus. So these are the top 10 countries for the number of adults with diabetes, that account for 60% of people with diabetes and 69% of global health expenditure. So just imagine 69% of global health expenditure is spent on diabetes alone. Okay, and as you can see, one of the top spenders for diabetes is India. Okay. So in your region, Southeast Asia, you have the most number of people with diabetes, about 74 million, followed by Bangladesh, probably because you're the biggest country in that region. You also have, aside from having the highest prevalence, highest number of people with diabetes, in terms of prevalence, you are just second because Mauritius has the highest prevalence in terms of adult population. But you can see that 1 in 12 people um, in India has diabetes, at least for adults. 1 in 12 adults in India has diabetes. So this graph shows diabetes and impaired glucose tolerance in adults for India. And as you can see here, the blue one represents diabetes. And in 2017, that's about almost 73 million, and it's expected to double in 2045. So if you want to be rich, go into endocrinology because you will never run out of patients because there are a lot of people that will develop diabetes. So you compare with our country, the Philippines, we have a relatively lower number of people with diabetes, but the prevalence is, but we have more people with impaired glucose tolerance, and the prevalence is expected to double in 2045. So the global burden of disease is really very huge, no? And because of the global epidemiology of diabetes, it has become the leading cause of end-stage renal disease, the number one cause of non-traumatic lower extremity amputation. It's not vehicular accident or peripheral arterial disease, it's diabetes. And DM is also the leading cause of adult blindness. So what are the determinants and risk factors for type 2 DM? So you can divide it into genetic factors, your demographic characteristics, behavioral and lifestyle related risk factors, as well as metabolic determinants in intermediate risk category. So for genetic factors, of course, your family history will play a big role. If you have parents with diabetes, you have a high chance of developing it through your lifetime. Um, Age, ethnicity can also affect behavioral and lifestyle related risk factors. Of course, obesity, physical inactivity, um, poor diet, stress, westernization, urbanization, those are all risk factors for developing DM. And intermediate risk categories are those who have history of prediabetes, such as the impaired glucose tolerance, um, history of a gestational diabetes, if you are an offspring of a mother who had diabetes during pregnancy, intrauterine malnutrition, or overnutrition. So all this can have an impact on whether you will develop diabetes or not. So here are the official list of major risk factors for type 2 DM, and this is usually the basis for deciding whether to screen patients or whether a patient is eligible to be screened or not. So you have overweight and obesity, physical inactivity, first degree relatives with diabetes, member of high risk ethnic populations such as African Americans, Latinos, Native American, Asian American, as well as Pacific Islanders. Females with history of GDM and delivering a baby more than 9 pounds, probably this is undiagnosed GDM. People with hypertension, elevated cholesterol levels, females with polycystic ovary syndromes. These are insulin resistant syndromes. Patients with impaired impaired glucose tolerance, impaired fasting glucose with an slightly elevated HbA1c, or those that we term pre-diabetics, are also all risk factors with type 2 DM. Other clinical conditions with insulin resistance, such as your severe obesity and acanthosis nigrans, also predisposes to type 2 DM, as well as having an age of more than 45 years old. So all this are qualified to undergo DM screening. So next we go to the classification of diabetes mellitus. So diabetes mellitus refers to a group of common metabolic disorders that share the phenotype of hyperglycemia. Okay? So the spectrum from normal glucose tolerance to type 1 diabetes, no? Type 2 diabetes, and other types of diabetes, as well as your gestational diabetes, are shown in this graph. In most types of DM, the individual traverses from normal glucose tolerance to impaired or fasting glucose tolerance to overt diabetes, whether at the beginning, probably not insulin requiring, but later on, it could be insulin requiring. Sometimes it's necessary for survival, especially if the patient is type 1. So the arrows indicate changes in glucose tolerance over the years. And as you can see, the arrow is bidirectional. So for type 2 and the other type. So if it's type 1, at the start, the patient has normal glucose tolerance, and the patient gradually loses his beta cells, and the patient enters a state of impaired fasting glucose. And then when most of the beta cells have been depleted, then they can proceed into becoming overt diabetes, and of course, if it's type 1, it's insulin requiring. So usually it's discovered when the patient develops diabetic ketoacidosis, usually. And usually this is precipitated by, let's say, an infection or severe stress or other comorbid illness that triggers DKA, and this is the time that the type 1 DM is diagnosed. For type 2 and other diseases, it could be bidirectional. So you can go from normal glucose tolerance to impaired and then to DM. And sometimes you can go back if you're just in the early stages of DM. You can actually try to reverse it by going back to your impaired fasting glucose or impaired glucose tolerance. Or patients with pre-diabetes can actually do some changes with their lifestyle, diet, exercise, and can actually revert back to normal glucose tolerance. And that's also the same for GDM or gestational diabetes. So sometimes patients with gestational diabetes, after they give birth, they develop in pre-diabetes after delivery, or sometimes they go to normal, and then after several years they go into IFG or IGT, and then later to overt DM if the hyperglycemia is not reversed. Okay, so this is the criteria for the different categories or in the spectrum of diabetes. So if you diagnose by FPG, fasting plasma glucose or fasting blood sugar, so the cutoff will be 100. If it's 100 to 125, so that's already considered diabetes. And if more than 125, that's 126 and above, that's overt DM, and so on and so forth. So we'll talk about this diagnosis in the later slides. So There are several distinct types of diabetes mellitus, and these are caused by a complex interaction of genetics and environmental factors. So your type 1 um, is described as a syndrome where there's continuous beta cell destruction, usually leading to absolute insulin deficiency. That's why this was formerly termed as insulin-dependent diabetes mellitus. But that nomenclature has been changed and has been deemed obsolete. Type 2 diabetes mellitus is usually characterized at first by insulin resistance with relative insulin deficiency, and once because of the insulin resistance and the continuous load on the beta cell as well as the toxic hyperglycemia, your beta cells can eventually die and lose its secretory capabilities, and therefore later on your type 2 diabetic patients can develop insulin deficiency. And these are the other types of diabetes, no? Genetic defects of beta cell development. So these are monogenic types of diabetes, diseases of the exocrine pancreas or acute or chronic pancreatitis, endocrinopathies, your acromegaly, Cushing's, glucagonoma, pheochromocytoma, hyperthyroidism, somatostatinoma, aldosteronoma, they all predispose patients with DM. So it's very important if you have patients with this to screen also for DM. So drugs, most especially your glucocorticoids, can also cause DM, infections, and other uncommon forms. So there's such a thing as monogenic forms of diabetes, and usually because of a single gene defect. So somewhere along the like insulin production or the receptor is the problem, or there's a problem with the secretion of the insulin. So it will depend so on which state of the glucose homeostasis is affected. So these are your monogenic forms of diabetes. So you don't need to memorize this. It's just nice to know that DM is not just limited to type 1 or type 2 DM. Okay? So we talked about impaired glucose homeostasis, and this is usually a precursor for the over-diabetes. So again, you begin with normal glucose homeostasis, and then you proceed with impaired glucose homeostasis until you go into over-DM. So if you test a fasting blood sugar and it is between 100 to 125, then you term it as impaired fasting glucose. If you do a 2-hour OGTT or 2-hour 75 grams OGTT and the value is between 140 to 199, you call that impaired glucose tolerance. If you test using HbA1c and it's between 5.7 to 6.4, we term it as prediabetes. So if you do 75 grams OGTT, usually you have an FBS with that, so you can have both IFG and IGT, or you can just term it pre-diabetes. So usually when you tell patients they're pre-diabetic, usually they get sad, but I always tell them that it's nice that we got to pick it up when it's just pre-diabetes, because it's an opportunity for us, for you, to be able to reverse it so that you won't progress into overt diabetes. So this is actually an opportunity and not a death sentence for our patients. So what's the criteria for the diagnosis of diabetes? So you have to memorize this. You have to learn this by heart. When I give the test, I will not put in the normal value. So you have to memorize this by heart. Okay? So if you test by HbA1c, your glycosylated hemoglobin A1c, the cutoff is 6.5, but it has to be from an NGSP certified standardized to DCCT assay. So not all labs have NGSP certified HbA1c. So you have to be very you have to scrutinize that, okay? Especially if your A1C doesn't match your FBS or your OGTT. If there's a discrepancy, have it done in an NGSP certified laboratory. If you do the FBS, okay, you have to be fasting for at least 8 hours. So small sips of water is okay. If it goes above 126, then you can say the patient has diabetes. If it's an oral glucose tolerance test on your OGTT, the cutoff is more than 200. If it's an RBS, a random plasma glucose or random blood sugar, the cutoff is more than 200, but the patient has to have classic symptoms of hyperglycemia. And what are these? That's your polyuria, nocturia, your weight loss, as well as your polydipsia. Okay, but the most common ones that I usually encounter in patients is nocturia and weight loss. So in the absence of unequivocal hyperglycemia, a criteria of 1 to 3 should be confirmed by repeat testing. So let's say, for example, the patient is 129 or 130, just one take, no symptoms. You can actually, it's warranted actually to just repeat it maybe after 2-3 weeks, even after a month. Check it again. If it's still elevated, then you're warranted to um, diagnose the patient. Or you can do another test. For example, you have 128 and you still are not so sure, you can do, let's say, you can confirm with a 75 grams OGTT or A1C to confirm the diagnosis of diabetes mellitus. So how do we screen? Why do we screen for diabetes? Well, majority will be asymptomatic and unaware that they have diabetes mellitus. And usually, DM may be present for up to a decade before the diagnosis. And some individuals with type 2 DM usually present with some diabetes-specific complication at the time of their diagnosis. Usually, it's sad when they come in with a diabetic foot already and it's up for amputation. Or it's also sad when the patient comes in uremic already from diabetic kidney disease and the diabetes has been neglected for quite some time. Okay, so patients should be screened for DM because if we treat DM, it will favorably alter the natural history of DM. Studies have shown that what you do early on in the treatment of diabetes will have an impact later on, many years down the line, on the status of their diabetes. That's what we call hyperglycemic metabolic memory. So if you achieve glycemic control early on in the disease, you decrease the risk of complications later in life. So, how to screen? At least for type 1 diabetes, it should be blood glucose rather than A1C that should be used to diagnose type 1 diabetes in symptomatic individuals. Ideally, an antibody panel is recommended. If you want to, ideally, to diagnose patients with type 1 diabetes, you need antibody panel. But if you want to screen for type 1 DM among patients with a strong family history of type 1 DM, we don't usually recommend antibody panels. It's still your blood glucose levels that is used for screening. How about for type 2 DM? Who should we screen? So, as I mentioned earlier, we screen patients who are overweight or obese with one or more of these risk factors. One or more of the risk factors I mentioned earlier, such as history of PCOS, sedentary lifestyle, certain ethnicities, patients with insulin resistance syndrome, etc., etc. In those without risk factors, then testing should begin at 45 years old. So usually we do it at, we use FBS to screen. So to test for diabetes, you can either screen with A1C, FBS, 2 or 75 gram OGTT. So usually the one that will be able to pick up the most number of cases would be your 75 grams OGTT because usually it's the postprandial that rises first before your fasting blood sugar. So The test that will be able to pick up more cases of DM will be your OGTT. If the patient is negative for DM, then you can repeat testing at least every 3 years. So, again, so when you screen for type 2 DM, you can classify it as prediabetes or diabetes or normal. So here are the tests that we use. Okay. So now, we go to understanding what happens if a patient is diagnosed with diabetes. We have to understand first the basis for the regulation of glucose homeostasis. So insulin, we will talk about insulin in the next couple of slides, is the major hormone that is um, famous for being associated with diabetes. And insulin hormone is a hormone associated with energy abundance. So if you have an abundance of food that provide energy, your body will increase its insulin secretion in order to facilitate the storage of such energy. So if you eat a lot of carbohydrates, it will be stored either as glycogen or later as fats. Your proteins will be taken up by your cells and converted into your amino acids are taken up by the cells and converted and stored as proteins, and these are all facilitated by your insulin. So insulin is an anabolic hormone. So there is an integrated control of glucose supply and utilization. So your glucose is utilized by your brain. So when you study, you take up a lot of glucose. Your muscles and your adipose tissue, they also take up glucose. So especially when you're exercising, your liver can also utilize glucose, but at the same time, your liver can also produce glucose or your hepatic glucose production. So some patients, they think that by not eating at all, they will have normal blood sugar, and they'll be surprised that their fasting blood sugar will be elevated even if they didn't eat anything at night. And that's mostly contributed by your hepatic glucose production. So your FBS is a reflection of your hepatic glucose production. So what happens if after you eat or during eating? So when you eat, so glucose enters your system, it is detected by your beta cell, and your beta cell will now secrete insulin. And your insulin will now facilitate the conversion of your glucose into your glycogen and be stored in the liver, or it will facilitate the conversion of your glucose to your pyruvate, and your pyruvate can now be incorporated into your fat, and your fat is now stored in your adipose tissue. And your glucose can also be, aside from being stored and converted into fat, it can also be taken up by your muscle and also stored as glycogen here and later used for like muscle activities, or it can be taken up by your brain. What happens if you're no longer eating or you're in the fasting state? For example, at night when you go to sleep, you're not eating anymore. So there's no continuous supply of your glucose. So what happens? Your alpha cells now, your pancreas now sense it and facilitates the secretion of your glucagon. And your glucagon will now help bring back your glucose levels back to normal. By how? Providing glucose into your circulation. And this is facilitated by the breakdown of your glycogen in the liver, by the stimulation of your glycogenolysis, as well as the facilitation of your gluconeogenesis by your glucagon. And together, your gluconeogenesis from your gluconeogenic precursor, as well as the breakdown of your glycogen, will now bring your glucose levels back to normal. So, this is what happens. Again, so when you eat, okay, there's an increase in blood, when you eat, there's an increase in blood glucose, and your pancreas secretes your insulin in order to facilitate its storage by increasing glucose uptake into your muscle and your fat, and facilitating glycogenesis, or the storage of glucose in your liver, as well as suppressing gluconeogenesis. Okay? And the uptake and all these processes will now bring down your blood glucose back to normal levels. Now, if when you go to sleep, you're not eating anymore, and your blood glucose starts to drop, it's now sensed by your pancreas, and your pancreas now will release your glucagon as a mechanism to increase your blood glucose levels back to normal. And how does your glucagon do it? By stimulating glycogenolysis and stimulating your gluconeogenesis, and both of this process will increase your blood glucose levels back to normal. So in the well-fed state, the predominant hormone is your insulin, and in the postprandial or fasting state, the predominant hormone is your glucagon. So the net effect of your insulin is anabolic. So here are the effects of your insulin in your metabolism. So we mentioned about muscle glucose uptake and metabolism, liver uptake and storage, conversion of your excess glucose into fatty acids, fat synthesis and storage, protein synthesis and storage, as well as the suppression of gluconeogenesis in the liver, as well as your fat utilization. So your glucagon, on the other hand, does the opposite. It breaks down your liver glycogen and increases gluconeogenesis in the liver, thereby enhancing the availability of glucose to the other organs of the body. So we've been talking about insulin. So how is insulin synthesized by the body? So the predominant cell, the cell that produces your insulin, would be your beta cell. And it is initially synthesized as a pre-proinsulin, which is cleaved during the post-translational modification to proinsulin, and then later cleaved to insulin. And your proinsulin, when that C chain is removed, or your C-peptide, it now becomes your insulin. So your insulin is composed of two chains, your alpha and your beta chain. It is linked by two disulfide bridges. Okay, and this is your C-peptide. So they are secreted in equimolar amounts in the pancreas, and your insulin is degraded by your insulinase in the liver. So the half-life is just 6 minutes with a duration of action of 10 to 15 minutes. So in the clinics, if you give a patient with, let's say, regular insulin 6 units IV, and you don't follow up with an infusion or a subcutaneous dose of insulin, the effects is just a few minutes. Okay? So, and because the half-life is only 6 minutes, it's hard to measure. So they use C-peptide as a measure of how much endogenous insulin is produced by your pancreas. So the measure of how much endogenous insulin production is your C-peptide. So your C-peptide is a useful marker of insulin secretion. So if you have patients with insulinoma, patients who have excessive production of insulin, the C-peptide will help you gauge whether you have increased endogenous insulin production. Or if you are, for example, looking at whether the patient is at the tail end of the spectrum, the insulin deficient spectrum of type 2 diabetes, you can actually test C-peptide. If the C-peptide is very, very low, then that means the patient is already insulin deficient and won't benefit from oral anti-diabetic medications anymore, and most likely requires insulin. So how do we regulate insulin secretion? So the primary major factor that regulates insulin secretion is your pancreatic beta cell. In the pancreatic beta cell is your blood glucose concentration. So when your blood glucose concentration increases, there is a corresponding increase in insulin secretion, and you will see a dramatic rise in the insulin levels with the rise of glucose concentration. Okay? So how does this happen? So when you have glucose, it's sensed by your pancreas by letting the glucose enter the cell through your GLUT2 transporter. So your GLUT2 transporter is located in your beta cells and facilitates the entry and sensing of glucose in your um, beta cell. In the muscle, the transporter that facilitates the entry of glucose will be GLUT4, and the mechanism by which the glucose enters the cell is by facilitated diffusion. Facilitated because it needs the GLUT transporters, but it doesn't need energy to let the glucose in. That's why it's called facilitated diffusion. So for the beta cell, it's GLUT2. In the muscle, it's GLUT4. So when the glucose enters the cell, it is phosphorylated by your enzyme glucokinase to glucose 6-phosphate, and this step is the rate limiting step for the glucose metabolism in the beta cell, and it's the major mechanism for glucose sensing. So this one will be the one to adjust the rate of insulin secretion in the beta cell. So when you break down the glucose, it produces ATP, and the ATP produced will now close the ATP sensitive potassium channel. And when you close this channel, you increase the intracellular potassium level, and when you increase the intracellular potassium level, this results in depolarization. And when you depolarize the cell, you open the calcium channel, and when the calcium ions enter, it will facilitate the release of your insulin from the secretory vessel. So your sulfonylurea drugs such as your glycoside, your glimepiride, etc., will prolong the closing of this ATP sensitive potassium cell in order to facilitate more insulin secretion. Okay? So the insulin release is inhibited by your somatostatin and your norepinephrine. So your incretins GLP-1 and GIP-1s are hormones that are released in the GI tract after a person eats a meal. And your GLP and GIP will have receptors in your pancreatic beta cell, and this will increase the rate of insulin from these cells in response to an increase in plasma glucose. And at the same time, it inhibits glucagon secretion from the alpha cells of the islet cells of Langerhans. So as opposed to your sulfonylureas increases insulin secretion. It's an insulin secretagogue. Now, your incretins and drugs that work by incretin effect will not only increase endogenous insulin secretion but also suppress glucagon secretion. And when you suppress glucagon secretion, it will help lower down your glucose levels by inhibiting gluconeogenesis and the breakdown of your glycogen. Okay? So, when there is an increase in your blood glucose levels and it's sensed by your pancreatic beta cells, there are two phases in insulin secretion. So the initial phase will be the immediate dumping of preformed insulin from the beta cells to help lower down the blood sugar, and then later on, if there's continuous elevation of your blood glucose, then there will be an increase in the synthesis of your insulin, and it will now have the second phase of your insulin secretion. Okay? So what happens in your target cell? So for example, this is a muscle cell. So your insulin will attach to its insulin receptor, and once it attaches to the insulin receptor, it activates a cascade of events eventually leading to the GLUT4 receptors going into your cell membrane facilitating glucose entry. So therefore, your insulin your insulin acts like a key that opens the door to glucose entry into your cell membrane, and this is via your GLUT4 transporter. And your insulin will downregulate its own receptors in the target tissue if there's already a lot of insulin that's attached to them. So um, there will be an increase in insulin receptors in starvation in the hope that there will be more glucose that will be able to enter the cell, and in obesity you will have a decrease in insulin receptors. So in type 2 diabetes, you can have insulin resistance, so your insulin are not working as well, so therefore your glucose cannot enter the target peripheral cells as efficiently as a normal individual. So that's the pathophysiology of diabetes mellitus. So I hope you understand how diabetes. That's the physiology of glucose homeostasis. So I hope you understand the basis before we proceed with the pathophysiology of diabetes mellitus in the second part of this lecture. So stand by for the next part of the diabetes mellitus lecture.